That was incredibly helpful. Thank you. A tremendous set of questions to motivate discussion. I only want to really make two comments, and then see what which of the other questions you've raised people in the audience want to pick up on. So the first point related to grounding clinical equipoise, and so I think we're in broad agreement that clinical equipoise is a useful and important concept that has broad application, including application to cluster randomized trials. So we're definitely in agreement there. I was just, I was trying to tell a story about where clinical equipoise comes from, right? And ethicists do their work in different ways, but there's sort of broadly two ways that you can talk about moral obligations. One is in terms of sort of free-floating moral obligations. There's a general moral obligation to X, and everybody has it, sort of ceteris paribus, right? And there are thousands of these things floating out there, and it can be really unclear who exactly has a duty to do what when. I'm interested, as a result of that, of talking about moral obligations as emerging from basically relationships. And that has an advantage in terms of the fact that when you talk about obligations actually emerging from defined relationships, it's clear who has the duty and to whom they have that duty. And it becomes suddenly something that's enforceable, and you know who has the duty, and you know who has to do what when. So that's my interest in talking about relationships, whether they're between the physician researcher and patient subject, or between the state and the research subject. I mean, it seemed to me that the state and research subject one sort of did the work that you wanted it to do, of sort of demonstrating the broad applicability of clinical equipoise. You could, for sure, tell a different kind of story that, strong political institutions within a liberal democracy need to have a mechanism like this in order to maintain the satisfaction of citizens, to quote Angie White. And we'll hear more about that. So there's a different kind of story we can tell. Anyway, so I think we agree. I think there's interesting stuff there about the foundations, though. Let me just, as my second comment, which will be briefer, just to talk about this table. I think actually the work of the moral rules actually runs across both the intervention and control groups. So the clinical equipoise question is not merely a question about what we do to the intervention group. It's a question really that says, is the comparison of bed nets to a no treatment control a comparison that's consistent with clinical equipoise? And so the reach of that moral concept is across both groups. Similarly, when we're asking about non-therapeutic procedures, the risks of those procedures need to be minimized both for participants in the intervention group and those for within the control group. There's the real risk with not separating out therapeutic and non-therapeutic procedures is that you can sort of mix in these therapeutic risks with the therapeutic benefits that may come from treatments. And as a result, you may inadvertently justify a lot of risk which really doesn't hold out the prospect for direct benefit. And I think that's the sort of justification that we don't want. Anyway, enough from me. Thank you. That was great.
Sarah Edwards, London, UK. A quick point of clarification. I'm assuming that you were using the idea of equipoise to justify a randomized cluster trial. Yeah. So in the bed netting case, would you be trying to argue that a prospective randomized cluster trial would be justified despite previous evidence from elsewhere? Or would you be simply saying that there needs to be some test of generalizability? And if so, could that be done through other sorts of study design?
I was trying to demonstrate how one might apply clinical equipoise looking at that trial prospectively. That could you use equipoise to examine whether that comparison of bed nets to no intervention was an ethically permissible thing to do in that context. And I think making that case, whether one could convincingly to a research ethics committee would appeal to things like the broad evidence base, but also biological and sociocultural differences in the Cambodian setting that perhaps haven't been adequately addressed by the evidence base. I think clinical equipoise actually sanctions a variety of designs. It's not merely a concept for randomized controlled trials of various sorts. So a variety of designs might be consistent with the equipoise requirement.
Not about equipoise. I like the concept of therapeutic and non-therapeutic, but I wonder if other terms might not be more widely usable. I think non-therapeutic might be easily replaced by scientific purposes or evaluation purposes, and I think that would be an assistance because firstly, it's not negative, and secondly, it enables the concept which I think the discussant raised about the benefits of evaluation measurements on patients. For example, in the bed netting study, the surveillance system tested control patients for whether or not, and treated them for malaria that was so detected, which would be a health benefit of being in a control group due entirely to the research procedures. And for the therapeutic procedures, I think that therapy has such medicalized connotations that we should probably replace it with the word intervention or some other such generalized word. That would also assist with distinguishing between the clinical intervention, which is often the subject of knowledge translation trials, and the knowledge translation intervention whose aim is to try and implement the clinical intervention, a two-level activity which I struggled with when I first met the EPOC collaboration in Cochrane. Thanks.
We've been struggling with those terms, and that's a very helpful contribution. Thanks.
I like it, and perhaps experimental and evaluative would be two words to use.
We have a question from Laura Lee Bockwell at the Secretariat for Research Ethics here in Ottawa. The question is, by taking clinical equipoise out of the doctor-patient relationship to make it more applicable to other types of trials, is it conceivable that clinical equipoise would become a criterion for non-health related studies? And several speakers have referred to cluster trials in education settings. How far would proposed cluster trial guidelines reach beyond typical healthcare settings? And would any study involving randomization of participants at the individual or community or group level be considered a trial to which clinical equipoise might apply?
I think that's a very valid point. I think when we started the project and we did our key informant interviews, we did include interviews with people, particularly doing cluster trials in the social sector for this. And it's clear that they face similar kind of issues in those sort of sectors. I think when we went on to do the work we've done, we largely restricted to health, largely just for making it tractable at this point in time. But I've already had discussions with several people in the room that says as we work through the health issues, we really need to think about the application of this to other settings, social sectors, school-based research, international development work. So I think there's been some value in keeping this ring-fenced in health for now, but I think a lot of the issues we raise are probably likely applicable with some modification to a whole range of other sectors.
But there's, for example, trials that have randomized litters of mice to different dietary interventions, and technically that's a cluster randomization trial as well. So one could expand the use of this design, I think, almost infinitely.
David Forster, Washington State, USA. And that last question in your comment almost stole my thunder, but I think I'm going to phrase it differently enough that it's still relevant. I think the tools of clinical equipoise and component analysis are great. And I'll consider you the tool maker, especially you, Charles. So I'm someone who's been out digging with these tools for 10 years. And my findings over the years is that clinical equipoise is a wonderful tool where there's a therapeutic intervention, whether it's medical, psychological, educational. But the minute you get away from research involving a therapeutic intervention, it's not very applicable. It's not easy to use, and I, quite frankly, don't use it. And so I think the applicability of component analysis to these cluster trials has to do with whether there's a therapeutic component or not. And if there's not, it doesn't apply. Now, contrary to that, I think component analysis is a much more useful tool in a broader setting. And so the component analysis works. And so I think that's the way we should be thinking about the application of the cluster trials.
Another comment about equipoise. I'm assuming you don't mind if we're a bit controversial from the floor as well. I guess the question that, I understand conceptually the importance of the role of clinical equipoise in clinical trial ethics. Where I get in problems is that I'm not convinced that it ever actually applies. And so the question, I guess I'm going to ask, the question would be, who is the judge of whether we have clinical equipoise? And should the opinions of the research subjects be included in the question of whether there is clinical equipoise? I think it'd be very hard, I'd be very hard pressed to come up with any situation where somebody has succeeded in getting millions of dollars to do even a non-clustered randomized trial, where you could honestly, with an objective, non-biased committee, come in and say that my prior probability of a success is 50-50. I just don't think so. I think the evidence is always going to be there. We can always invent a story in the way that you did, and I don't mean that in a negative way, because I think that they were always inventing stories that will pull out some part that will justify why we need to do yet another study. But at some point, that becomes unnecessary and wasteful. And I guess my real question is, who's going to be making that decision? Who should make that decision?
So there's a really interesting literature on equipoise and what on earth it means and who has to be in equipoise, and it's become a bit of a cottage industry, I think. And so there's patient equipoise, there's doctor equipoise, there's researcher equipoise, there's community equipoise, there's industry equipoise. I'm not sure what that's supposed to mean, but so who is supposed to be in this sort of ill-defined state of equipoise? I think there are broadly two approaches to thinking about equipoise, and one is sort of thinking about it as a state of uncertainty that an individual experiences, right? And if you understand it that way, so a lot of people interpret equipoise in sort of Bayesian terms, and there's a nice sort of connection there. But I think the difficulty with that approach is that it just doesn't sort of seem to sort of be psychologically true that investigators doing seemingly ethical studies are in fact in equipoise in that way. People doing studies, reasonably enough, often really believe in the experimental intervention. I mean, it's lots of work doing a study. I mean, of course they do, right? So that sort of seems like, for me, that makes that interpretation of equipoise, or that way of thinking about it, not as useful. I like to think about it really as really a property of the evidence that exists at the beginning of the trial, and it might be something that would emerge out of a systematic review that is motivating or part of the preparatory work for a cluster randomized trial that's part of building the justification. So it's a property of the state of evidence that really just says something like, we don't already know the answer to this question, right? Because if we already know the answer to this question, it's unethical to randomize people in the study. So I think that's what it's getting at, and in this context, the people who make that judgment are the research ethics committees.
Can I just follow up with with a more specific question. In the BedNet example that you've used, if you get informed consent from every participant in that study, you would have to provide them for the informed consent with the existing evidence of the efficacy of BedNets. Under that situation, I would be surprised if there would be very many, if any, people who would agree to take part in a study where they wouldn't get a BedNet. I certainly wouldn't. And the fact that mosquitoes eat at a different time, to me, would be relatively minor, and I'd look at it being done a different way. So again, the question is, who's judging that equipoise? Because the participants should have a right to make that decision through informed consent, and yet the scientific review committee or the ethics boards are making it divorced from the context of those individuals.
Yeah, I mean, which is just another way of making the point, and I think correctly, that equipoise is a necessary condition, but not a sufficient one, right? That there are for important reasons requirements of informed consent, and pragmatically, if people are just going to vote with their feet, for pragmatic reasons, you may need to rethink the design.
I would agree with what Charles said, and I would add that to me, equipoise is a framework to think about things. And in most real circumstances, we cannot make a categorical decision about whether or not there is equipoise. There are instances when there has been a Cochrane review that says we cannot decide between that and the other, then the evidence is pretty strong that there is equipoise. But most of the times that's not, and that's why we have ethics boards who need to help us with it.
Charles mentioned that an investigator is rarely in a state of true equipoise, in the sense that the investigator is naturally enthusiastic about the intervention that they've worked perhaps for years on. I once posed that question to a prominent investigator, and what he told me was interesting. He says he distinguishes between emotional equipoise and intellectual equipoise. Emotionally, he definitely wants the intervention to work, but intellectually, he feels he has to stand away and let the scientific process take course. Anyway, I thought that was interesting.
I think the BedNet example also heightens comes back to Katrina's point about these issues not necessarily always about the individual benefits or harms at the individual level. The key issue in that example would be whether healthcare systems or donors should actually invest in insect nets. And so as an individual, if someone was going to give me a free BedNet, I would say great. But actually, the issue is the opportunity cost, that if we give out bed nets free, which are going to be ineffective, the opportunity costs in those countries or to those donors are great. And so it also brings in this idea about, from whose perspective. So the health policy issue, dealing with Katrina's Q6 or 7, is really quite important.
I'm Abha Saxena from the World Health Organization from Geneva. One is very minor given all the discussion that has happened. The paper and the presentation was focusing on clinical equipoise, and it's not really clinical, and especially in the context of cluster randomized trials, most of the times it's not clinical. It could be socio-behavioral, it could be preventive, diagnostic. So to me, just to say equipoise rather than clinical equipoise makes more scientific sense. The second question is more related to the cluster randomized trial and the control group, and the assumption being that having a control which gets nothing is okay because we are providing, we don't know whether in that context, in the context in which the cluster randomized trial is being done, the standard of care is our control. But if you go to some of the guidelines, Helsinki and other guidelines, which are saying the standard of care should be the best proven therapeutic or preventive standard, and then how do you correlate? So could you do no action at the control level? Would that be ethically justifiable? It's difficult because I think most CRTs are actually not, using control as the standard of care. But I sometimes feel troubled because I think with randomized control trials, we have a different approach versus cluster randomized trials.
There are special and pressing concerns that emerge out of global inequalities in the distribution of health and access to health care, I mean, obviously. And so you know, the question is what, you know, we say that the various treatment arms in a trial need to be broadly consistent with competent care, but competent care where exactly, right? Is it the care that's available in a developing country, or is it a developed country standard of care? That's a really difficult question. I mean, I think part of the concern there is one that individuals in developing countries might be particularly susceptible to exploitation in health research, and that there ought to be procedures in place to guard against that possibility. I think there are really important protections that need to be a part of guidelines that address the developing country context, including a requirement that health research ought to address local health needs and priorities, right? And furthermore, that there should be some reasonable prospect of access to interventions once the study is complete. I mean, there at least needs to be some kind of plan about how, in fact, people in that country might benefit from a treatment that's identified, an intervention, sorry, that's identified to be efficacious. So I think those are just mandatory and clear ethical requirements. What you need beyond that in a developing country setting is contentious, I think, and there's a debate, as you well know, about the requirements of ancillary care in developing country context, and I'll just flag that as a really hard question. So thanks.
Hi, I'm Alison Paprisa from the Ontario Ministry of Health and Long-Term Care, and have a comment that I think builds on question 11 and 12, which have to do with societal benefit, and just wanted to sort of put in there how I see these questions come up in the world that I work in. So where we are, we talk a lot about policy interventions, complex strategies at the ministry level, and basically the benefits and harms are discussed and agreed on by elected officials, or through governance they trickle down to regional authorities, hospitals, others who have authority to make these decisions. So really when it comes to the question of are we going to do something like a cluster randomized trial or couple research with the intervention, a lot of the benefits and harms are already set in terms of what the intervention is. And the discussion is then about what are the benefits and harms of the evaluation aspect. So when I think about your two arms there, I would say that really I see us focusing on the side that doesn't have to do so much with efficacy. People have already weighed the benefits and harms, but there is this question about, you know, what are we going to learn? Generally seeking a societal benefit in terms of new knowledge, and what will it take us to get there in terms of burden and cost.
Okay, thank you very much for the observation. Thank you to Charles and Katerina for a very stimulating session.